Hello, thank you for joining us. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. On behalf of the National Forum and our partners, welcome to Unseen and Untreated, Confronting the Connections Between Heart and Kidney Disease, a call to action. We're convening this discussion during National Kidney Disease Month. Thank you for being here. Your participation reflects a commitment to improving prevention, early detection, and treatment of chronic kidney disease and to illuminating its fundamental connection to cardiovascular health. I want to thank Boehringer Ingelheim, whose sponsorship enables the National Forum to bring you, leaders from across healthcare, public health, patient advocacy, academia, government, and industry together to address a critical issue that demands collaboration across sectors and disciplines. What is the critical issue? It is a simple one with profound clinical, economic, and social consequences. More than 35 million US adults have chronic kidney disease, or CKD. That's about 1 in 7. Yet 90% are unaware of it. Hypertension and diabetes are the leading causes of CKD. And once kidney disease develops, it increases the risk of heart attacks and strokes. Kidney and cardiovascular disease fuel each other, accelerating decline. We will hear more about this shortly. Despite clear guidance and simple, effective, available tests, screening among high-risk patients is pathetically low. This is a missed opportunity. Early diagnosis and treatment can slow progression, reduce cardiovascular events, and prevent enormous expenditures. We will see this during this convening, just how dramatic a difference early diagnosis and treatment can make. Every taxpayer has a stake in intercepting kidney disease early. In 2021, 13.5% of Medicare fee-for-service beneficiaries age 66 or older had a diagnosis of CKD, yet this population accounted for about 1/4 of total Medicare fee-for-service spending, $77 billion. So what are we going to do about it? Over the past several months, the National Forum has been in conversations with organizations dedicated to advancing kidney disease prevention, detection, treatment, policy, and awareness. These discussions included experts and leaders of federal agencies, kidney organizations, state initiatives, clinicians, and advocates who recognize both the urgency of this issue and the opportunities for progress. Today's convening is designed to broaden that dialogue, gather input, and create a path for us to join forces to drive change. We've seen how quickly care can shift when screening becomes routine. For example, when A1C testing became standard in 2015, clinicians could detect diabetes earlier and intervene sooner. A similar shift is possible for kidney disease. The tests exist. The challenge is integrating them consistently into primary care workflows for patients at the highest risk, including people with hypertension and cardiovascular disease, our people. We've seen the power we can amass by joining together to produce real results. State legislators said that when they saw dozens of patient, clinician, and public health organizations jointly advancing a set of policies to expand people's access to evidence-based care, our unity signaled strength and importance. As a result, 29 states enacted 75 policies that we jointly recommended. That was just 3 years ago. So we can do this. That brings us to the call to action, a draft of which is included in the online program book for this convening. Our goal is to multiply the respective strength of each organization represented here today through many signatories, just as we accomplished in 29 states with the joint policy statement. Your organization has an opportunity to start the healthcare system on a course correction by signing the call to action. It focuses on three strategies. One, elevate recognition of the connections among hypertension and cardiovascular disease, diabetes, and kidney disease among clinicians and people at risk. Two, increase screening and early diagnosis of kidney disease in high-risk patients. And three, ensure supportive policies that make screening, diagnosis, and linkages to treatment standard practice. Insights from today will help refine the call to action and shape our next convening in April, when we will explore how organizations can align their strengths to advance this work. We already know we're in good and strong company. The American Diabetes Association and American Kidney Fund have teamed up to raise awareness and drive early diagnosis and treatment. The National Kidney Foundation is leading policy and systems change efforts. The American Heart Association is on track to issue a guideline on cardiorenal metabolic syndrome in the second quarter of this year. Last month's issue of the American Journal of Preventive Cardiology included a call to action to improve the standard of care for early diagnosis and management of disease. Through the effort we are undertaking today, we will collectively amplify the call and accelerate the action. Let me briefly outline today's program. We will begin with a personal story that illustrates the stakes for patients and families. We'll then review the scope of the problem we're trying to solve and the barriers that limit early detection and follow-up care. We'll hear examples of successful state and system-level efforts that are helping point the way forward, and then we will have an overview of the call to action, gather your feedback, and close with participant reflections. A few quick housekeeping notes. This meeting is being recorded and will be available for playback. At the bottom of your Zoom screen, you will see the Q&A and chat features. Please use the chat to share comments and resources and submit questions for speakers through the Q&A. We will monitor both throughout the session. Before we begin, I want to share my vision for what success looks like. A vacant building usually does not connote success, but in this case, seeing healthy people passing a kidney dialysis center that closed because it was no longer needed will constitute life-enhancing, family-strengthening, healthcare cost-saving success. Now, we will begin our program with a story about the lived experiences of people and families affected by kidney disease. Their stories drive home why early identification and treatment matter so much. It's my pleasure to introduce Tiffany Jones-Smith, CEO of the Texas Kidney Foundation. Tiffany is a powerful advocate for improving awareness and care, and in her personal capacity, she will share her perspective on why addressing kidney disease earlier is essential. Tiffany, thank you for being with us. The floor is yours.
Thank you, Dr. Clymer. Good afternoon. First, I want to thank the National Forum for Heart Disease and Stroke for bringing us together and creating space to talk about prevention, not just as an aspiration, but as an implementation challenge. Because kidney disease is not abstract to me. It's not just public health, it's not just policy, it's family. My brother experienced kidney failure. My cousin experienced kidney failure at just 21 years old. And in my family, we have lost 16 relatives connected to kidney disease. Most people assume kidney disease takes lives through kidney failure alone. But in our family, most of those 16 relatives died from heart attacks and strokes, the cardiovascular complications kidney disease accelerates. So when I speak about this, I'm not speaking from a distance. I live up close and personal with the disease because I have it too. Eventually, I began asking a question many families ask when something keeps repeating itself. Could something genetic be happening here? The answer was yes. In our family, the underlying issue is APOL1-mediated kidney disease, AMKD. I live with that knowledge every day. I take a pill every day. I monitor my numbers, and because of that, I've been able to hold off the worst ravages of kidney disease. For years, I also lived with an enlarged heart, but today, because of science, lifestyle, and understanding my numbers, I no longer do. That taught me something powerful. The difference between crisis and prevention is often not science, it is knowledge and the systems that allow people to act on that knowledge. I come from a long line of activists, preachers, accomplished teachers, and scientists, so laying down wasn't an option. I began with the science that could support the policy. That is why I was part of the Janssen Delphi Consensus and Systemic Review on APOL1 associated nephropathy. Because if we wanted policy to move, it had to be grounded in evidence. But after 75 years of medical progress, the science exists. What is missing are the systems that deliver prevention where risk actually begins. For decades, prevention has followed a familiar model. Hospitals partner with nonprofits, screening events are held, patients are told to follow up. That's important work. But screening without navigation is not prevention. Then 2020 happened. We lost 40% of our revenue. We lost volunteers. We watched families suffer. And Kevin and I looked at each other and said, if we're going to do this, we either go big or we go home. So we chose to go big. We liquidated our 401k. That's right, everything we had saved. Not to run another program, but to build infrastructure. And we did not lay down. We stood up. We built a moderate complexity laboratory. We brought UACR and EGFR testing into communities. We brought genetic testing into communities so families like ours could understand inherited risk like AMKD. We trained community health workers, and through our Knowledge to Action 2030 initiative, we are building an implementation system that moves people from knowledge to action, and that can be duplicated any place. In just a few years, we have impacted more than 150 counties across Texas, served over 34,000 Texans with point of care services. And what are we seeing? What we are seeing is striking. 36% of the people we test show evidence of kidney disease, which means the risk is not theoretical. It is already in our communities. We join coalitions, we move policy, and we are here consistently, steadfastly, and respectfully building the systems prevention requires. We did not lay down. Because the greatest barrier to prevention is not science, it is funding the implementation of prevention where risk actually lives. That is why we put skin in the game, because our people were dying. But here's the hopeful part. When I look at that picture of my family taken before the hardest times, I don't just see loss. I see hope. I see science. I see Texas ingenuity, because we already have powerful tools. What people need first is something simpler. They need to know where they stand. So today, on World Kidney Day, a great day, my call to action is simple for us. If we want the next 75 years to look different from the last 75 years, we must fund the organizations that are actually implementing prevention in communities. Because when science, clinicians, policy leaders, and community organizations move together, prevention will finally reach the people who have been waiting 75 years for it. Thank you.
Tiffany, thank you for sharing your powerful story and for your passionate and dynamic leadership. Your story reminds us that the consequences of late detection are not abstract. They affect real people and real families every day. And very importantly, you underscored that there's hope for better outcomes. To better understand the broader scope of the issue, we're now going to look at the national landscape of kidney disease and the barriers that continue to prevent earlier diagnosis and treatment. Our next speakers will help frame the urgency of the challenge and the barriers we continue to see across the healthcare system. Our first speaker in this segment is Elizabeth Montgomery, National Vice President for Clinical Practice Innovation and Population Health at the National Kidney Foundation. Elizabeth works closely with clinicians and health systems across the country to improve chronic kidney disease recognition and management in primary care settings. Elizabeth, thank you for being here today.
Thank you, Dr. Clymer, for including us, and thank you to everyone who has made the decision to allocate several hours of their day-to-day to talk about kidney disease and what we can do differently. The presentation that I'm going to speak to is really talking about looking at kidney disease and elevating the K in cardio-kidney metabolic care. They want to just speak to the idea of the traditional public health vision of prevention and being a river, right? That the idea is we don't want to spend a lot of time and resources pulling people out of the river, that it is much more effective if we can get upstream to understand what is pushing people in and work to mitigate that. So when you think about chronic kidney disease today, the reality is that most people are being identified downstream where there are significant efforts required to preserve and save lives. In reality, in the United States today, most people at risk for kidney disease are not tested. Most people with laboratory evidence of kidney disease do not have a diagnosis. Most people with CKD are not on disease-modifying medications. Most people with CKD will not receive nephrology care before the need to start dialysis. And probably most importantly, and something that Tiffany mentioned a couple of minutes ago, is that most people with kidney disease will not survive till advanced CKD because of the cardiovascular complications that are associated with any evidence of kidney disease. So we're looking at this dynamic and recognizing that there are a lot of people in the river that potentially we could do something about if we really worked to mobilize and recognize that of the 37 million Americans living with kidney disease, only 33 million of them are unaware. My next slide kind of speaks to the reality in terms of the impact from an equity perspective of kidney disease. Communities of color are disproportionately affected by CKD. Black Americans comprise 13% of the US population, but represent 33% of individuals living with end-stage kidney disease. They are 3.4 times more likely to develop ESKD than their white counterparts. Indigenous Americans are almost twice as likely. Hispanic Americans are 1.5 times more likely, and Asian Americans are also in this category for elevated risk. Social determinants, as my next slide speaks to, play a significant role in the development of kidney disease as well. Poverty, food insecurity, limited academic attainment, living in rural settings, all of these factors significantly increase the probability that someone will deal with chronic kidney disease at some point in their lifetime. So you may be asking yourself, why is this happening? And the answer to that question is there are a lot of barriers that come into play. My next slide speaks to that. That the reality is, the first thing you need to keep in mind is that kidney disease is asymptomatic and silent on onset. That the earliest symptoms of kidney disease will be some cardiovascular event. As one very wise primary care clinician in Michigan once said, kidneys don't cough. People don't know they have it, so you can't necessarily have the expectation that people are going to go to their doctor and complain about their kidneys because they literally are unaware. The only way they can know is if they get tested. Clinicians have some misperceptions about kidney disease. Historically, the perception is there's really not a lot that could be done, and that end-stage kidney disease is just something that's going to happen downstream, or the perception that I'm already doing everything I need to do to manage hypertension or manage diabetes gets in the way of really understanding that cardiovascular implications of kidney disease are already present and maybe not even recognized to be there. hospitals and health networks experience the same sort of challenges. It's very unusual to see chronic kidney disease as a quality target on a health system dashboard. There are limited connections to what's happening with kidney disease and impacts on ER visits, hospitalizations, and readmissions. And then this question of risk scores and how all of this translate while getting better still is somewhat problematic. The government has historically underinvested in kidney disease, with a lot of attention going to heart disease and a lot of attention going to diabetes, but not a lot of investment in understanding kidney disease and its relationship in that cardio-kidney metabolic framework. And there have been limited levers for them to drive change. Healthcare payers contribute to the challenge. They have a very end-stage focused understanding of return on investment for chronic kidney disease care. So there's limited investment that's actually occurring in prevention from many health plans. And a lot of that is associated with the understanding that there's churn in terms of membership and a resistance to invest in preserving the health or make a significant investment in prevention that may not necessarily demonstrate ROI while that individual is in a health plan. And then employers don't necessarily have the understanding today that chronic kidney disease drives cardiovascular outcomes. So there's limited investment in that population as well. So what do we do with this? Well, the next slide kind of speaks to, first we have to address significant gap, because we aren't going to be able to improve anything until everyone at risk for kidney disease is tested. And this data that's presented here was from 2019, was a publication by the National Kidney Foundation and LabCorp that illustrated that in the United States, most people are not tested. Individuals with diabetes are more likely to be tested, but we're still working to bring that testing rate to an acceptable level. And hypertension testing, as Dr. Clymer mentioned earlier, is pathetic. It's 10 to 15% of people actually being tested. The next slide speaks to, excuse me, what does this mean and why does this matter? So I've just delivered, a lot of information that suggests that we really have a significant problem we need to address, and there's a lot of opportunity for growth. But this slide speaks to a bright spot. The graph presented on this slide comes from a paper that was published from the Indian Health Service in 2017. Now, I would argue that the Indian Health Service is the least resourced health system in the United States. For every dollar that's invested elsewhere in healthcare, IHS gets maybe 40 cents. And they are serving a population that is enriched for chronic disease, including kidney disease, and enriched for social determinants that can contribute to the development and progression of the same. And they realized over 25 years ago that they were going to need to make some investment to do something different because the system couldn't sustain what was happening. And so they made the decision to implement a really aggressive approach to identifying and addressing chronic kidney disease in people with diabetes. They effectively ensured that the majority of people with diabetes were tested on an annual basis, and there was an enhanced use of ACE inhibitors and angiotensin receptor blockers. And what it yielded over time was the green line on this graph that illustrated that this investment, this basic investment in kidney disease-related care, reduced incident diabetes-related kidney disease by 54%. I challenge anybody in the call to replicate this model, this commitment to driving change. The National Kidney Foundation has leaned in here, and we have been employing a strategy called CKD Intercept, which I believe is our next slide, that articulates this idea that prevention is not a prescription, as was mentioned earlier, it's a system. It is a systems-based focus on whole person health. The next slide speaks to CKD intercept in this understanding that as we advance through these slides, we can't just look at physicians and patients and just focus on education. That's not going to be enough to solve this problem. It's important, but not enough. We need to bring the entire health system into the conversation, including the community and community-based organizations, to ensure that we're looking at this holistically and we're working together to drive change. And the next slide really speaks to this discussion of this model of collective impact. The National Kidney Foundation has been deploying the collective impact model nationally for almost the last 5 years to bring stakeholders together, to get them aligned and get them activated around how to drive change. And that historically, we've spoken to almost 1,000 senior leaders from integrated health systems, payers, employers, community-based organizations, pharmacy groups, specialty societies, to get everybody aligned behind what needs to happen. And then at the local level, get that granular momentum that can drive change. A big part of the work is getting people motivated, but the second part is giving them a direction for where to go and understanding of what they can do to drive change. And the next slide speaks to that idea. So several years ago, we had the privilege of working with the amazing team at Million Hearts around the hypertension control change package. There was a conversation that got started that the Million Hearts team was interested in understanding how to bring interventions for kidney disease into the hypertension control change package, while at the same time the National Kidney Foundation was interested in developing a change package for CKD. And a change package is essentially the recipe for how you drive change. Because saying to somebody in healthcare, sure, go do better, is a Herculean task when you think about the health system change and the idea of changing workflows and finding education. So the change package vision that was articulated by Million Hearts created a framework to make it easy, identifying the change concept, change ideas, and tools and resources. And I had the privilege of working with Hillary Wall, who was absolutely fabulous in this collaboration for us to bring our suggestions into her process and her work, and the NKF to move a change package forwards. So the information on the hypertension change package is on the slide. The next slide speaks to our chief medical officer, acknowledging how important it was for us to have this collaboration and understand how we could leverage this idea of a structured approach to change in terms of driving change for people with kidney disease. The next slide provides you with information on the CKD change package that was created by the National Kidney Foundation. Our current iteration of this is slightly different than the hypertension change package because most people recognize hypertension. Very few people recognize kidney disease and have a clear model for how to get an institution engaged in wanting to drive change. So our change package includes everything from basic understanding of kidney disease through how do you speak within your institution to get others engaged in the process of change, what does that process of change look like, and what are tools and resources that have been created by others, nationally, not just the National Kidney Foundation, other organizations who have done good jobs. Their suggestions are included in these materials. What does this mean? How effective has it been? The next slide speaks to that. This year, the National Kidney Foundation was recognized with a Global Quality Award on the basis of the information presented here. Sanford Health is the largest rural health system in the United States. At the time we were working together, the health system spanned 4 states. Now they're in 6 states. There was 137,000 people in their population at risk for kidney disease. When we went to them and said, we would love to collaborate with you, their rates of testing and diagnosis had room for improvement. So we brought the change package, and we brought the National Kidney Foundation Population Health Partnership team into the discussion to help them implement the change package within their institution. And the outcomes were that in a 10-month period, the rate of CKD testing increased by 70,000 lives. In 10 months, the rate of diagnosis of kidney disease among their population with diabetes went from 20% to 73%. Again, thousands of lives impacted. And there was a five-fold increase in the use of SGLT2 inhibitors in that same period in that population. So we've demonstrated that it is conceivable to do this work at scale, focusing on getting the system to work in a way that optimizes kidney disease care in a primary care setting. I'd like to just end on this note that, there are several pillars that are associated with chronic kidney disease care in the United States. But I wanted in this particular conversation to highlight SGLT2s because of this graph. This graph is incredibly powerful from my perspective because it illustrates the difference in terms of impact that we all can have by getting people diagnosed and on reasonable care faster. So the left axis, or the y-axis of this graph is eGFR. So rate of kidney function is on the y-axis. The x-axis is numbers of years from starting to requiring end-stage kidney disease. If you look at the intersection on this graph, you will see that if someone starts an SGLT2 inhibitor when their kidney function is very compromised and they are in stage 4, one of the more advanced stages of kidney disease, the impact of that medication is 1.9 years of additional time between the need for end-stage kidney disease dialysis or transplant, which is important. There's no question it's important. But if you look up on the y-axis and you consider what the implementation of this category of drug would mean if someone got on it sooner, before their kidney function was actually allowed to decline, you could extend the time between where they are right now and the need for dialysis or transplant by as much as 26 years. So when you consider, in your own lives, I don't know how many people on this call know what their current eGFR or UACR testing looks like, but if you can consider the impact that getting 26 years between you and a dialysis chair, what that would mean to you and your family, I would consider that, or I would suggest that you likely could see the value from a human perspective for why this work is so important. I'm going to stop there talking about the issue, and I'm now going to turn it back to Dr. Clymer, and we're going to talk a little bit about cost of kidney disease.
Elizabeth, thank you so much. And I think that last graph is not just powerful in your eyes, but to anyone. It so dramatically shows the potential we have before us to move the needle a long way in a positive direction. So thank you for that. Love the example of the Indian Health Service, which, as you correctly point out, is chronically under-resourced, underfunded. The success that they had and the collaboration with you, so congratulations. And thank you for pointing that out, because that adds to the hope that we're all going to carry out of this meeting of a brighter future for people who we can assist by helping them get diagnosed and helping them manage their condition early when they can achieve that kind of massive increase in life expectancy that you just showed. And kidneys don't cough. Yeah, you're right. That is really pithy. Elizabeth, thanks for helping frame the scale of the challenge and the gaps and the opportunities. Of course, you're talking about moving care upstream really resonates. Now we're going to hear from Holly Bodie. Before we do, we actually have one quick question from Kevin Smith. And I think it's for Elizabeth, just a question to clarify. When you say CKD, are you including the early stages like 1, 2, and 3A, or simply those diagnosed at stage 3B?
That is a great question. And so I am not a clinician. I can only speak on behalf of the team that I lead. But when you look at the heat map, when you look at how chronic kidney disease is stratified. Any individual that has evidence of albuminuria greater than 30 milligrams per gram of albuminuria in their laboratory findings is considered for having kidney damage. And when that albuminuria is persistent for more than 90 days, that becomes a demonstration of chronic kidney disease. So we look at this question of addressing those individuals. And just for perspective, almost 60% of people who fall into the frame of kidney disease have albuminuria, but a preserved EGFR. And our position is, the position of the population health team at the National Kidney Foundation, is we don't want you to wait to intervene until someone has effectively lost the function of an entire kidney. That there are lots of interventions that can be employed today that can reduce that albuminuria, reduce the damage to the kidney that it creates, preserve kidney function, and then again, get on to that perspective of adding not just life expectancy, but health span, healthy, productive living for a much longer period of time, because we started to address the underlying albuminuria that can contribute then to the decline in kidney function if it's allowed to persist.
Thank you both to Kevin Smith for an excellent question and Elizabeth Montgomery for a great answer. And Elizabeth, I really appreciate your pointing out the nuance, but really significant difference between lifespan and health span. So thank you. Next, we will hear from Holly Bodie, who's Vice President and Chief Advocacy Officer at the American Kidney Fund. Holly will share her perspective on the policy landscape and the barriers that patients and providers face in accessing early detection and care. Holly, we're glad you could join us today. And I understand your camera's not working well, but we can hear you, so we're eager to hear your voice, Holly.
Great. Thank you so much. I really appreciate being included in this important event. As Dr. Clymer mentioned, I'm Holly Bodie, and I work at the American Kidney Fund. So we're an organization that focuses on people with and at risk for kidney disease. And we aim to be part of a person's journey from prevention all the way through dialysis. And in recent years, we have been increasingly focused, as I know obviously others in the kidney world are, on how do we incentivize earlier intervention and earlier screening and diagnosis for people with kidney disease. The statistic that 40% of people crash into dialysis is really the thing that drives me every single day. That's just a shameful statistic, and one that just doesn't have to be that high. And there are a lot of things we can do to move that number down. And I wanted to talk today. In the past few years, we've done 2 different studies. In the first, I did have a copy of the cover of this story, but anyway, it's on our website. If you Google American Kidney Fund Medicare costs, that will show up. So we worked with an economist from Columbia University and a couple of years ago, and he did an analysis that showed that if more people were screened, it's called the Reimagining Kidney Care from Crisis to Opportunity. So that examined the economic opportunity of identifying and treating earlier stages of CKD. So this chart here, I think everyone knows this, but I still think seeing it up close and personal is really quite shocking when you look at the cost to Medicare of the ESRD patient versus the average Medicare patient. So it's really quite shocking. And I think, there are plenty of opportunities there to bring that $80,000 number down. Next slide, please. So this study found that if you reduce the share of people living with stages 3, 4, and 5 kidney disease by 25%, it could save Medicare an estimated $9 billion annually, and commercial payers and employers an added $2.8 billion annually. This is before accounting for any costs associated with increased screening and use of treatments. And so this is a message that we are taking up to the Hill, that it's important to look at the cost to taxpayers, if not even human cost, but simply financial impact of so many people ending up on dialysis. And so part of the message we're taking up to Capitol Hill is that if you can save Medicare money, if private insurers can save Medicare money by doing more screening, more prevention, more early treatment, perhaps that savings could be shared with those private insurers, the Medicare savings. This is not something that's been done before, sharing public savings with a private entity, but we also know that our healthcare system strongly works on financial incentives. And so this is an approach that we've been talking to people on the Hill about and doing some kind of demonstration program. Next slide, please. So we also did another study. This was about a year ago, last March, called Healthy Workforces, Sustainable Futures, Why Employers Should Invest in Early Kidney Care. So this was done by the same organization, the same person, the economic, Neil Mattis is his name, economics professor at Columbia University. And he estimated that at least 11 million people, 11 million workers out of 150 workers, or 7.4% of the US workforce, have CKD. And this is, even though this is a huge number, it is probably underestimated simply because so many people, as we all know, are undiagnosed. So this study that Mr. Mattis did found that if we can get employers to invest more in screening people for CKD and treating early stages of CKD, it could save employers $107 billion to employer health plans. And so that, I think, is a really staggering number. And we are also working with employer groups right now to get them to focus more on kidney disease and kidney disease prevention and treatment. Again, not just the human cost of this disease, but the cost to people's pocketbooks and to employers' pocketbooks. So we have had some decent success in getting traction with this issue. Obviously, we all know there are plenty of things happening in Washington on a daily basis that take people's attention away from many things, but this is something we're working closely with employer groups on in order to get them to invest more in preventing and screening for early kidney disease. And with that, thank you for your time. And again, both of these studies are on our website, and I'm happy to answer any questions.
Thank you, Holly. Boy, those were some very compelling cost figures, and you make a great point about the cost to taxpayers in addition to patients, and certainly that extends to employers. And
I have to correct the record. It's $35 billion in annual savings. I'm sorry, $107 billion is the amount that employers currently spend on people with chronic kidney disease. So apologize for that error.
That's a very big number. So apology unneeded and correction accepted. Thank you. Well, we appreciate, Holly, your comments. And boy, the burden of kidney disease is clearly very substantial, and opportunities for improvement are clear. But one of the most consistent themes that we've been hearing is that primary care clinicians are facing enormous pressure with limited time and competing priorities that can make early detection difficult to implement consistently. To explore that reality more directly, we're pleased to welcome Dr. Randall Maxey, an internal medicine and nephrology specialist with Advanced Community Medical Care Corporation in Inglewood, California, and past president and board chair of the National Medical Association. Dr. Maxey is going to help us better understand the barriers that primary care clinicians face on the ground. Dr. Maxey, thank you for joining us.
Thank you so much for the opportunity to speak. And when I was an intern at Columbia University, we called a primary care doctor practicing in the community the LMD. And he was the guy that made all the mistakes and we would correct them. So I am coming on as the LMD, who hopefully is aware of what is going on. May I have the next slide, please? So just for a quick look, we have prevalence, which is the number of people in the population that have a particular disease. And we compare that with awareness. And just from a graphic standpoint, you can see that a number of people have the disease of chronic kidney disease, but a very small percentage are aware at all. There's a big disclaimer there. Next slide. So more than 37 million Americans are affected by kidney disease. 90% of these people are unaware. The major driver of cardiovascular mortality is CKD. We always say that it's not the kidney disease that kills you, but it's the kidney disease that makes everything else kill you, like heart disease, strokes. And we know that this is a major public health cost. Next slide, please. So the economic impact of doing dialysis, which I used to do, versus prevention. We know that for one dialysis patient is almost $100,000 to $120,000 per year of cost, whereas it may cost less than $2,000 or $3,000 to do the test that prevents continued prognosis towards dialysis. Next slide. So it's so simple that if we do something called screening, there are two key tests that alone can detect most chronic kidney disease. Serum creatinine can allow you to calculate, the laboratory to calculate the estimated glomerular filtration rate. We know that urine albumin to creatinine ratio, known as ACR, can also detect early kidney disease. So screening high-risk patients is very important. Now, the literature says do it annually, but my experience says do it quarterly. So if you first identify these high-risk patients, who are they? The ones with diabetes, hypertension, cardiovascular disease. Order a urine test, very simple, and do that at least annually. And again, we talked about doing it quarterly for high-risk patients. Request abnormal tests be repeated within 3 to 4 months. You can then save the end-stage renal, the estimated glomerular filtration rate and ACR, and initiate treatment and monitoring. Very important. So ACR testing in the office is not ordered by the LMD or the primary care doctor, internal medicine. Very unfortunate that's not done. Urine and albumin in the urine is frequently ignored until it's too late. And we have limited CKD training for internists, primary care, family practice, etc. But it's very important to educate these primary care doctors about clinical priorities, not only managing high blood pressure, knowing what's going on in the urine. So the referral algorithm that I like, refer to a nephrologist, a kidney specialist, or even an internist, if the eGFR is less than 60. Refer if rapid decline, such as 5 cc's of clearance over a course of a year. We want to make sure we recognize that. Refer if the ACR is above 300 milligrams %. Refer if hypertension is resistant. And we do want that number to be less than 120/80. It's been shown that there's a logarithmic progression in untimely, unfortunate events if you don't get that pressure down. And when I refer if the electrolytes are abnormal or there's structural abnormalities shown. Next slide. So we know that there are disparities in the population, and this graph simply demonstrates that the African American community in America has a higher number of risk for mortality and morbidity from CKD, and that's very important compared to whites. So evidence-based treatment ladder, blood pressure control, get that pressure less than 120/80. ACE inhibitors or ARBs, these are foundational medications that should be given. I tend not to give ACE inhibitors to patients of color, more angiotensin receptor blocking agents, but these are foundational. But either or, you must do that. SGLT2s that have been spoken about before, such as Farxiga, is important. Finerenone or Kerendia is important. And diabetic and lifestyle management is important. And we understand that as your kidneys fail, you may have some toxicity from increased protein. And that's especially true in older adults. Next slide. So cardiovascular risk amplification shows that as you go through the various stages of chronic kidney disease from 1 through 4, the amplified risk of mortality and morbidity go up almost logarithmically. Next slide. So how do these things work? The SGLT2 inhibitors reduce intraglomerular pressure and hyperfiltration, and this continues to further damage the kidney. Finerenone reduces inflammation and fibrosis, both in the kidney and in the heart and the brain, so we want to use that. GLP-1 agonists also reduce metabolic stress, weight, and also cardiovascular risk. But I tend to combine all of those in a different therapy. Next slide. So just looking at this slide, it shows the relative risks of the progression of each of these, but let's go to the next slide. I'll do more demonstrative. So I use something called a stacked therapy. Next slide. And what does that mean? My mother-in-law taught me how to make soup. Instead of adding the onions and the celery all at different times, everything goes in at once. This shows you how we can reduce the risk of progression of CKD to almost zero if you use a combination of each of the ones, the ARBs, the ACEs, the SGLT2s, the finerenone, and the Ozempic as well. You can get that risk to almost nothing where you combine to show that you can almost stop renal failure within the life of this patient. Next slide. So with electronic medical record, you can set your system so it can tell you what the EGFR, make that calculation, alert you when that calculation goes below 60, alert when the ACR is abnormal, and also can trigger CKD staging and also give you referral guidance as well. So key takeaways and strategies. 1, CKD is common. It's also very silent, so people don't know that they have it without your ACR testing. There's population risk awareness that we have to do. There's a simple community screening can save lives. Primary care education is very important. Let's educate the doctors. That's very important. We hope we come to the National Medical Association for that. There are many of those gaps in screening that result. The early referral is the name of the game. The treatment prevents dialysis and morbidity. Next slide. Thank you very much and for your attention. I appreciate any questions you may have as we move on.
Dr. Maxey, thank you very much for those insights. While the barriers are real, we're also seeing encouraging examples of progress, and we're going to get to those in just a moment. But I understand that Holly Bodie is double booked today and needs to leave. So I want to get one question to her before she steps away. It's from Rob Starr at NIH. And he asked, do the economic data that you presented include costs of screening and early detection? Holly, are you still with us?
It does not look like Holly is still on.
All right. Well, we will hold that question for the Q&A portion. And again, thank you very much, Dr. Maxey. We appreciate your insights. And now we're going to hear from several leaders who are implementing strategies that are either new approaches to earlier detection, improving workflows, strengthening team-based care, or otherwise helping ensure patients are connected to treatment sooner, and they're doing so in real world settings. We're going to begin by returning to Tiffany Jones Smith, who will share more about the work underway in the Texas Kidney Foundation. Tiffany's going to highlight strategies focused on early detection, community engagement, and closing the diagnosis gap. Tiffany, we're happy to hand the microphone back to you.
Boy, this has been such a wonderful discussion today. Very lively. I love all the data that everybody's presented. I want to steal all their slides and bring them to Texas. Um, Thank you again for having me. I'm Tiffany Jones Smith, Chair of the Texas Chronic Kidney Disease Task Force and President and CEO of the Texas Kidney Foundation. I just want to make a quick note. I'm sharing task force and coalition highlights for this discussion, but I'm not speaking on behalf of HHSC. The webinar title, Unseen and Untreated, is exactly right. CKD is often silent until late, and when we miss it early, we also miss a major amplifier of cardiovascular risk. Texas sees this burden every day. Dialysis prevalence and transplant wait lists are the downstream result of late identification. And nationally, the majority of people with CKD don't know they have it until the disease is advanced, just like Dr. Maxey said. So our core message for this webinar is simple. Kidney measures the long inside heart and health prevention. If we're assessing blood pressure, diabetes, and ASCVD risk, we should be identifying CKD early and acting earlier because it changes risk, it changes management, and it changes outcomes. Upstream early detection are the most important words in the prevention dictionary. And importantly, this is not only an adult issue, we are also focused on children because early kidney injury can begin earlier than the system is designed to detect. The 2025, next slide, our Texas priorities, close the testing and diagnosis gap. So the 2025 state plan for CKD treatment from the task force included 8 total recommendations. Today, I'm sharing 3 practical moves that Texas is prioritizing, plus a pediatric emphasis that is increasingly urgent. Priority 1, make UACR and EGFR routine in high-risk adults and close the diagnosis loop. Our operating model is straightforward. Order, diagnose, act, track. Testing is necessary, but it's not sufficient. If UACR and EGFR is abnormal and the system doesn't convert that signal into a documented diagnosis and guideline-aligned follow-up, we don't actually move outcomes. Priority 2, expand access through screen, educate, connect. In Texas, we've learned that screening at scale works when it's integrated into trust settings and paired with a warm handoff. Similar to what Elizabeth said earlier, the differentiator is what happens next. Confirm the result, connect to primary care follow-up, and refer appropriately. Priority 3, expand access through telehealth and patient-friendly results. Telemedicine can expand nephrology and transplant reach, but only if it's supported by reimbursement and practical workflows. We also emphasize the importance of reporting results quickly in plain language with clear next steps, because delayed or confusing reporting is where follow-up falls apart. And here is the pediatric priority we want to add to this webinar. Protein spillage as an early red flag. In children, protein in the urine, especially when persistent or clinically significant, should be treated as a serious signal, not a minor abnormality. We are working to educate pediatricians and primary care that quote unquote protein spillage should trigger confirmation and quantification, not just a single dipstick,
1 minute.
timely referral pathways when warranted, and consideration of genetic testing when the pattern suggests an inherited kidney condition, when there's family history or when clinical features point to a genetic etiology. The reason this matters, genetics can shorten the diagnostic odyssey, clarify risk for the family, and support earlier, more targeted management before irreversible damage accumulates. And I think several of us have said the same thing. Slide 3, practical lessons and call to action. Now, I'm always, whenever y'all invite me to do something, I'm going to give you a call to action that we've got. Let me close with the lessons we've learned that generalize beyond Texas. First, screening must trigger action. If abnormal UACR and EGFR or pediatric protein spillage doesn't lead to a clear pathway, it's not a program, it's an event. Second, pair kidney detection with the visits people already show up for. Cardiometabolic touch points are the natural on-ramps. And third, close the loop. Timely, understandable results plus a defined next step is what increases follow-up. Fourth, scale through implementation levers, not education alone. Use EHR prompts, order sets, standing orders, team roles, and closed loop follow-up, and scale the workforce. Pharmacists and team-based models for adults, plus pediatric and primary care education to catch early warning signs in kids. Call to action for the webinar, treat kidney measures as standard inside heart health prevention. 2, close the UACR testing and diagnosis gap with workflows that make the right action easy. And 3, include pediatrics. Normalize protein spillage as an early red flag and promote appropriate genetics consideration when indicated. Thank you.
Thank you very much, Tiffany. Next, we'll hear from Jen Koberstein, manager at the Wisconsin Collaborative for Healthcare Quality. Jen and her colleagues are using data and quality improvement strategies to help drive earlier kidney disease screening and better management across health systems in Wisconsin. Jen, thanks for being with us today.
Hello, thank you for having me, and thank you for convening this meeting. I'm excited to talk about what we're doing here in Wisconsin. Next slide. The Wisconsin Collaborative for Healthcare Quality is a statewide organization that includes about 85% of the primary care physicians in Wisconsin. And about 4 years ago, we decided that CKD is a quality priority for us and began working on CKD identification, treatment, and improving upstream screening in all of our populations. Next slide, please. As we began our work, we looked at increasing annual screening for high-risk patients, improving diagnosis documentation in primary care, supporting the race-agnostic EGFR reporting, sharing best practices, and strengthening capacity to manage CKD in primary care. And we had a number of ways that we did that. Next slide. Next slide. Okay, there we go. We have 34 publicly reported measures on our website. This past year, we had our first CKD measure called our CKD Cares measure. It assesses the percentage of patients with diabetes who receive an annual screening of both the EGFR and UACR. So every health system that's a member of WCHQ now publicly reports this data, and that's a way that we drive improvement. We collaborate, we bring health systems together who are doing well to share with health systems who need to improve in this area. In addition, we have a number of internal measures that we've created, including CKD diagnosis on the problem list, which we're now stratifying by stage of CKD. using guideline recommended therapies, and we're continuing to build that suite of measures. Next slide, please. A couple of things that we've learned doing this work is that when patients are diagnosed with CKD, 85% of them have a documentation of receiving guideline recommended therapies, ACE, ARBs, SGLT2s, or nonsteroidal MRAs. So we're doing well once patients are identified. We have one health system, ProHealth in Wisconsin, that is screening 93% of patients with diabetes annually with a UACR and EGFR. So it's very impressive. We brought them to meetings. They're sharing how they're doing this work, and they're trying to raise all boats in Wisconsin so that more people can have an outcome like this. Next slide, please. So as I said, 93% kind of shocked us all when that was a publicly reported measure. It's been validated. They came and did a presentation. They have clear clinical expectations for screening from the top down. They have health record prompts that identify patients who are due for testing, and they have a number of places where those touch points happen. They have strong clinical leadership, oversight, and accountability, and they demonstrate that primary care workflows can increase screening rates. Next slide, please. So where our opportunity remains here in Wisconsin is CKD screening gap. 67.5% of patients with diabetes receive both required tests annually. We'd like to see that at 70% by the end of this year. That's our goal right now. Here's a big area where we have a gap. About 60% of patients with lab evidence of CKD have CKD on their problem list. If it's not on their problem list, it's unlikely that their doctor has spoken to them about it. I saw an earlier comment in the questions about somebody that had been told that they had CKD, but it doesn't sound like that conversation was very robust. We really have worked with our healthcare providers to help them understand how to talk to patients about CKD and the importance of making lifestyle changes, being on medications, regular screening, all of those kind of things. We've created a toolkit. Next slide, please. We created a CKD toolkit for all of our primary care providers that has an overview, when to screen, how to talk to patients, all of those kind of things. It's free. It's on our website. It's open for anybody to use. You are more than welcome to go to our website and take a look at our chronic kidney disease toolkit and share that with anyone you'd like. Next slide, please. We recently discovered that some of our health systems have not, and some of the labs in Wisconsin have not switched over to the race-agnostic EGFR. That's a priority we're currently working on. We are taking a look at all of the health systems in Wisconsin, and we'll be working with the National Kidney Foundation to help everybody switch over to the race-agnostic EGFR. Next slide, please. I think that is it for me. There's my contact information. You can feel free to reach out to me if you have any questions.
Jen, that is so impressive. Thank you very much. I've been in the prevention and health systems change arena a long time, and I'm learning so much from what you're doing. It's innovative and clearly really powerful. I mean, 93% at Pro Healthcare, that's phenomenal. So congratulations.
Thank you.
Thank you for setting a high bar for us.
Yeah, it looks like there is one question about what are the numbers in Wisconsin for underserved who don't have insurance. We stratify all of our measures by race, ethnicity, payer, geography, and we do pay very close attention to underserved populations, and we work in our quality improvement teams on those populations in particular when we do this work.
Thank you both for the question and for that answer. Next, we're going to hear from Tom Duvall, the Director of the Division of Special Populations and Projects within the Seamless Care Models Group at the Centers for Medicare and Medicaid Services. Tom will share perspectives on how care models and system-level strategies can support earlier detection and improve care for patients with kidney disease. Tom, welcome.
Well, thank you. I just want to share the perspective and talk a little bit about some of the work we've done at CMMI and sort of how we think about some of the issues around CKD. It's not going to be obviously that different from all that we've heard already today and sort of all these great perspectives here. I think it's just really pointing out sort of the special place and how important it is for Medicare. In general, the government obviously plays a very big role for patients on with kidney disease. Medicare has had that special entitlement since 1972. We can see the stats about how much money the government saves when a patient sort of stays CKD for longer. And that's definitely a big piece of it and kind of a big piece of the thinking. Here at the Innovation Center, our goals are to decrease costs and improve quality of life and quality of care, and hopefully try to do both at the same time. And CKD and sort of larger efforts around kidney disease seem to fit this sort of overall push here. Even given the special entitlement for folks under 65, there's a real benefit towards having folks be CKD for longer from their own quality of life perspective and from a reducing cost perspective, and their ability to even sort of maintain a normal life there and not sort of have that much higher level of expenditures and be on the Medicare program. So I think that's sort of the clear theoretical framework, and it's the reason why kidney disease and CKD will always be an important area for CMS and for CMMI. So this is one I want to highlight kind of two of our efforts that we've done at the Innovation Center around CKD. So one is the one we've already been testing, the Kidney Care Choices model. That's our coordinated care ACO model, which includes patients with CKD 4-5. Though the initial results that we have did not show effects on changes in progression, we did see, and frankly, one of the biggest, most striking results we saw from the model was a bigger focus on optimal starts metric, so starting more patients at home or with a fistula. So it shows that this payment model only included folks with late stage CKD when there was already sort of on the path to dialysis, and it shows the opportunity for sort of further upstream integration with the goal of delaying that path to dialysis and or preventing it overall if we could. I also wanted to highlight the access model, which is a new model being offered by CMMI. The idea there is testing new approaches to CKD care for technology-supported care options with outcomes-based payments. It is focused on sort of 4 different diagnosis areas, 2 of which are CKD related. So one of which is CKD3, and one is looking at those cardio-kidney metabolic issues that sort of cause and ultimately lead to kidney damage. So I think the goal of that one is really trying to bring in some new ways of providing care and seeing would technology-enabled care that's sort of done at a lower cost, sort of, and utilizes AI and other technologies, how effective is that going to be at sort of seeing these results that we're hoping for, and in hopefully helping patients better manage their care. So I think just wanted to highlight some of these efforts, and that this is an area that we are sort of very closely thinking about and engaged on, given the importance to CMS here. Thank you all.
Tom, thank you very much for that. Great information. Before we move on to our next speaker, just a quick reminder that if you have questions, we'd love to receive them. Please use the Q&A function down at the bottom of your Zoom screen. Now, another important theme that has emerged in many of these conversations is the potential role of team-based care, including pharmacists, in expanding access to screening and supporting ongoing patient management. To explore that opportunity, we're pleased to welcome Ben Blumel, who's the Executive Director and Senior Vice President for Research and Innovation at the American Pharmacists Association Foundation. Ben, take it away.
Thanks a million, John, and really glad to be here today. Appreciate the opportunity to frame all of this in a place where I think that we can help. So over the last 3 decades, this evidence base for team-based care, and in particular the role of the pharmacist, as you just pointed out, has grown. The APHA Foundation itself has been involved in dozens of initiatives that have shown the benefits and the importance of having a pharmacist well integrated into the team. But so as not to save everything until the end, I'll prequel it with the fact that that one of the huge challenges today remains that pharmacists aren't enumerated as providers in the Social Security Act. And we need support from colleagues and partner organizations to help us to get into a good place so that we can help to be a part of the solution for improving health throughout our communities across the country by getting the pharmacists well integrated as members of that primary care team. And like I said, we've conducted dozens of different initiatives that have demonstrated the role of pharmacist in primary care. I'm going to just touch on a few of those. So we had an initiative that focused on hyperlipidemia. Data said that after 2 years' time, only 32% of patients are left taking their lipid-lowering meds. In this initiative, where we included pharmacists in the team-based care, 93.6% of patients persisted with their lipid-lowering therapy. In osteoporosis, a condition that we haven't touched on yet today, but 80% of people are walking around with osteoporosis and they don't even know it, just like we heard the statistic earlier of 90% with CKD who don't know it. Well, imagine that if you had a community where practices across that community engaged in a screening event to identify and refer at-risk patients, and over 70% of the patients through those efforts who showed up were either at high or moderate risk and got referred to a physician and got prescribed a therapy for that condition that they were completely unaware of. Our work in diabetes across that spectrum for both employed populations, where we've seen improvements in clinical, economic, and humanistic outcomes, where essentially we're saving thousands of dollars per person per year at the net level by having those patients engaged. And in the same underserved populations where we've implemented those initiatives, achieved the same clinical reductions in A1Cs in a very short period of time that's helped people to reduce their risk. Imagine you've got a team of people in the pharmacy team that's trained up as lifestyle coaches that are implementing the National Diabetes Prevention Program and keeping a very high percentage of patients completing that coursework to actually not go on to develop type 2 diabetes. Think about the fact that pharmacists are the primary vaccinator of adults in this country since the pandemic. We've got amazing work going on right now in HPV vaccines and cancer prevention, and the role of the pharmacist in doubling, tripling, or quadrupling the number of people addressing unmet needs there. We've got a cardiovascular health plus program where pharmacists conduct a SDOH assessment with their patients, and they conduct a stroke risk assessment and an EKG in store, and are able to identify people at 2 to 3 times the rate they would be normally expected to exist in a normally distributed population. Why? Because we see those high-risk individuals. We have a medication profile for that. And imagine that you had people on the team, and we would propose that this is the work we would love to do with everybody here who's working on CKD, is that every one of these patients will have a pharmacist who's responsible for maintaining a current active medication list in the interoperable health record, optimizing the patient's medications, and avoiding that huge bill and all of those effects associated with medication misadventuring. But again, to come full circle, in order to really address all of those challenges and so many of the eloquently discussed challenges here already today, we got to get the pharmacist on the team in a credible way. We got to credential them just like their physician colleagues. We got to pay them just like their physician colleagues. And we've got to utilize the skills and the talents of the pharmacist, because guess what? Medications are one of our primary treatment modalities, as discussed earlier by Dr. Maxey with the stack therapies, and we can be a big part of the solution in helping to make that happen. So I'm here to be a part of the action agenda as this meeting is concluding, and really looking forward to talking to a number of you about how we can get pharmacists well integrated into the programs that you're implementing and into the prevention systems and processes that you're developing in your communities.
Indeed. Thank you very much, Ben. The evidence that outcomes improve and people are better off when they have access to robust pharmacist services is strong, clear, and compelling. So I think it's up to us to overcome the policy barriers to people's access to this evidence-based care. And I want to thank not only Ben, but all of our speakers for sharing very exciting and compelling examples. What we've heard today reinforces an important point. While the challenges are significant, solutions are already emerging and being proven in many places. So we now want to open the floor for questions. As a reminder, you can submit questions through the Q&A feature, and we'll do our best to address as many as possible in the 20 minutes that we have available to us. We've received a number of thoughtful questions already, and I look forward to getting answers. So we're going to begin with one from, it's part question and part a very compelling testimonial from Verlin Maldonado. And I apologize, Verlin, if I have mispronounced your name. Verlin says, my dad, age 83, just started dialysis last week. But now I'm finding out that about 20 years ago, he and my mom were told of his early stages of CKD. While he has lived an additional 20 years without dialysis, he's had 2 strokes in the last 10 years. I think that early signs may not have been communicated clearly, what it means and what can be done for prevention early on. Maybe patients with later stages of CKD can share testimonials with those in early stages to communicate what they wish they knew earlier. Elizabeth, I don't know whether at NKF or Jen, you all in Wisconsin, as part of the communications work that you've been doing, have examples of putting Verlin's recommendation into practice.
So first I want to thank Verlin for making the comment, and I'm so sorry to hear that your family is now contending with end-stage kidney disease. The reality of it is that what you've described is the story for people with kidney disease. If you look at the data around kidney disease, 80% of people with undiagnosed kidney disease have diagnostic information in the electronic health record that's not being responded to. The National Kidney Foundation, obviously from my comments earlier, we are focused on changing that the data is available. We have strategies to walk systems through how to leverage it so that other families don't have to have the experience that you are currently contending with, in order to try to change the model that people can't understand that they have kidney disease unless it's clearly articulated to them by the care team. So we need to ensure that people are tested. We need to ensure that diagnosis occurs. We need to ensure, as Jen mentioned earlier, that clinicians are provided with the information they need to interpret the tests in a timely way, translate that information into language that a person can understand and integrate, and then ideally ensure that they follow the progression of kidney disease over time, so that there is a concerted effort, like Dr. Maxey articulated, to ensure that as progression occurs, there are additional interventions that can be employed that can help amplify the impact and ideally slow that progression. Jen, I saw that you unmuted.
Yeah, I just want to add one thing that we do at we have an annual event, cardiometabolic event, education event, and our after lunch speaker is always somebody with lived experience. who tells their story about how things were or were not communicated to them, what their experience was trying to access care in the system, and they're speaking to providers. And we make sure that we put those folks in front of the providers at every event to remind them about how important it is to have good communication, to make sure people really hear what you're saying, really can digest it, that they have the support that they need to do the next thing. So we are doing some of that right now, always should do more.
Jen, Elizabeth, thank you for that. Ben, I'm mindful of all the pressure that we put on physicians, particularly other clinicians, and particularly in primary. I know I've heard the phrase force multiplier applied to pharmacists as part of the care team. I'm wondering whether pharmacists could be part of this solution about.
Can I add something in really quick to that? What we did in the state of Texas was we also saw that same thing.
Looks like Ben, what's that?
Yeah, I think Tiffany was telling her story about how Texas added pharmacists to the team, right, Tiffany?
Well, I was actually I was just going to say that we added um, mandatory reporting of biomarkers. We passed some legislation to do that, so that now instead of you not knowing and just monitoring, because it wasn't that physicians in Texas were trying to do something nefarious or just were ignoring information. It just wasn't added to a protocol, and they were told to monitor, and they were doing their job. They were looking at other things that were more pressing in the care model. So once we did that a couple of legislative sessions ago, that we expect to see things like that make a difference in that area. And we also, as an organization, what we did was presented the KDIGO heat map, showed the patient what they needed to do. When I say that we trained community health workers, that's what we did. We did the things that we did not have as patients, that just weren't there. So we filled in those gaps, and that's a model that we can present to anyone and help anyone with. So anyway, I just wanted to put
Tiffany,
that out there. It can be
so
done.
glad you brought that up. The community health workers and promotores can play such a valuable role, tremendously helpful. Tom, are at CMS opening any avenues of opportunity to enable some of these non-physician providers to play more substantial roles?
I think in some ways, ultimately we're limited by statute. That's the big thing. Obviously, we've sort of heard and talked to pharmacists there for a while. I think CMS's big focus is on sort of using the ACO structure, like the Kidney Care Choices model, like the Medicare Shared Savings Program. And I think within ACOs, the goal is to really give provider groups that relevant flexibility to work with who they think would be most appropriate and kind of build the care infrastructure however they can. So I think the hope there is that with that flexibility, and also with MA plans who sort of don't have some of the same limitations as they do in traditional Medicare, that we can, I think, really encourage the flexibility to get the best care for patients.
Great.
Yeah,
Thank you very much, Tom.
John, maybe I could jump in and make a
Please.
point on the pharmacist side. And Tom, to this very point, essentially, since we're not enumerated in the Social Security Act, the big part of the challenge is that we need more people on the primary care team, without question. We sit in forums in the diabetes space and other chronic conditions where essentially there's no question about the fact that we're valuable members of the team. And everybody agrees that each member of the team needs to be paid fairly for their services in order for that to work. And we've got to get that going. But just sit back and imagine for a minute, if you had a resource in this system that saw over 301 million visits through the front doors of their practices every 10 days in this country. Wouldn't you want to engage them? Well, that's your community pharmacist, okay? And so what we need to do is that we need to all put our heads together and say, hey, what is part of this prevention system that we want to have out there? And actually, how do we prevent this medication misadventuring that we have throughout our system today, that is absolutely a disaster? We spend $1.55 on misadventuring for every dollar that we spend on medications in this country. And if you do the math on that from 2025, that's $1.076 trillion a year that we're spending in the United States on medication misadventuring. And that could be the misadventuring associated with people who are identified as needing a medication and aren't yet getting it. And so the reality is that this is the really significant case in CKD, and we could help, but we need to have systems. We need to have incentive alignments so everybody who's participating is paid fairly. And I think that if we put our heads together, we could actually really transform things, but we can't keep doing things the same way that we have in the past and expect a different result in the future.
Let me add a
Indeed.
couple points if I could.
Please, Dr. Maxey.
So one, we have a lot of faith organizations, churches, mosques, and we need to use those places to get them aware of this problem. We should have church screenings, mosque screenings, temple screenings. That's where the vast majority of people are, and we should educate them. That's one. Number two, we need to get down the cost of the medications. There are a lot of heavy co-pays and deductibles that stop people from getting the medication, much more than the cost of dialysis would be if they go to chronic renal failure. So we need to look at a different way than just making money of how to do this, and it will leave more money for better things. But we need to have community health screening, lower the cost of these medications, or find a way to subsidize them. I think it would be a lot cheaper than dialyzing patients for $120,000 a year.
Dr. Maxey, great point. Thank you. And your point about cost is important. And of course, it's complicated. I was looking yesterday at the KFF health expenditure analysis tool and at long-term healthcare cost trends, and the portion of aggregate healthcare costs accounted for today that goes to prescription medications is the same as it was in 1960. That's at the aggregate level. But the out-of-pocket cost that people actually experience has grown significantly. So it's complicated, and we need to look carefully at it and solutions. Thank you for that. And Dr. Maxey, we have a question for you from Christine Kylan. Christine, I apologize if I mispronounced your name. Christine asks, would GLP-1 be considered in your evidence-based treatment ladder?
Yes, they are. And we know that they cut the cardiovascular risk as well as the SGLT2s and the MRA agonists as well. So they are in that cost.
All right, thank you. And we have a question from the National Forum's Chief Science Advisor, Dr. Stephen Sidney, who asks, should family history of CKD be an indication for early screening?
Can you repeat that?
I'm seeing Tiffany nod.
Yeah.
Dr. Maxey?
Can you repeat that question?
Yes. Should family history of CKD be an indication for early screening?
Absolutely.
There you go. That was
John,
concise.
Dr. Clymer, just to add to that, I think that it's important to also underscore that the guidelines recommend that anyone over the age of 60 be tested for UACR as well, because kidney function will just naturally, normally decline in many people. And so if you are over 60, you should ask for that test to ascertain whether you've experienced that age-related kidney function decline.
So, Elizabeth, just to clarify, you're making a really important point. I think as a layperson, I want to make sure I'm understanding. I think you're saying that EGFR declines over one's lifespan naturally, and you can age in a healthy way with a declining EGFR, but the UACR may give you very important additional information that would help detect whether you have kidney disease or you're at risk. Is that correct?
100%. And it's really important for you to know if your kidney function is declining, because then you want to stay away from nephrotoxic drugs or things that could potentially injure your kidneys and accelerate that decline, and amplify the impact. So that's why the recommendations are as they are.
And there's a follow-on to that. As you get older and have back pain, stop using that ibuprofen and aspirin and other NSAIDs that are going to make it worse.
Thank you. Thank you. Very important clarification. Thank you for that point. The next question, we heard here in the last couple of minutes that kidney disease doesn't get as many resources as cardiovascular disease does. And gosh, those of us in the cardiovascular health arena feel like we're way under-resourced. So we're all swimming in this pool of limited, insufficient resources, which leads us to, I think, a very important question from the National Forum's past chair and the former president of the American Academy of Family Physicians, Warren Jones. And he's directing his question, Jen Koberstein, to you. Dr. Jones wants to know, does the Conversion Foundation in Wisconsin help you reach key players?
And I am not familiar with the Conversion Foundation, so
so that would be a foundation created with the capital coming from the sale of a nonprofit health system or nonprofit health plan.
Yep. Oh, Advancing a Healthier Wisconsin and the Wisconsin Partnership Program. Yep. So we have just submitted an application to Advancing a Healthier Wisconsin to for our work on the race agnostic EGFR. And we work very closely with them on a lot of our chronic disease work. So thank you for the explanation.
Yeah, absolutely. And thank you, Dr. Jones, for the great question. Tiffany, what about in Texas? Are y'all having any success in obtaining resources from conversion foundations in your state?
Texas Kidney Foundation has not received resources from the Conversion Foundation in our state. We'd love to, but what we were doing was, like I said, building the implementation system, because there just wasn't one in community for underserved, skeptical folks, and so we had to go in and just do what needed to be done. Now we're reaching out to folks and trying to see what we can do.
All right. Thank you.
Dr. Clymer, just to add to that, the National Kidney Foundation has been working successfully with the Missouri Foundation for Health, which is also one of these conversion funds. And ironically, they were the funder of our program that worked to engage community-based pharmacists as agents to increase CKD testing in rural settings. And we'll be submitting that paper on Friday, so hopefully it'll be published in a couple of months. So there are funds in other states, and there are opportunities to leverage that funding to build CKD programs. That's fantastic. Great to hear. And also, Elizabeth, I love your optimism about the publishing schedule. So
Tiffany, you asked a question, and I'm wondering, I think it may have been for Holly Bodie. You asked, do you have this data by state? Was that for Holly? Okay, so we'll circle back to Holly and not only get the answer for you, but we'll share it with everyone. So thank you for that. Um, Dr. Rob Starr asked about another question about economic data and whether they cover costs of screening and early detection. Elizabeth Montgomery, in your presentation, you touched on economics as well. Can you uh, answer that question, at least for the data you presented?
I certainly can. So, Dr. Starr, thank you for that question. I don't know, maybe 3 years ago, there was a paper that was published by a team at Stanford. I believe the first author is Cusack, that looked at the cost effectiveness of chronic kidney disease screening in the world of SGLT2 inhibitors. And in that economic model that they put forth, they considered not only the cost of screening, but the cost of the therapeutic intervention. And one of the outputs of their work was the idea that given the impact that SGLT2 inhibitors as a class can have on slowing the progression of kidney disease, that the savings would be such that it would support population level screening for kidney disease, not just screening among people with risk factors. So there is evidence out there that there is an ROI. We work with data that the National Kidney Foundation published as part of a program that we did with Care First, a large Blue Cross Blue Shield payer in the Mid-Atlantic. We did a pilot program with them in 2018, 200 primary care clinicians, over 100,000 lives were in the pilot. And we were able to demonstrate at 24 months, just by improving basic CKD care, rendering a diagnosis and putting anybody at stage 2 or higher on a care plan, there was a 30% reduction in ER visits, hospitalizations, and readmissions among people with stage 3. Right? You know, we have a lot of conversations about costs of savings for downstream in stage 4 and stage 5. This paper demonstrated that there is an ROI that includes all of the expenses associated with improved prevention care that can be seen as soon as 24 months when a CKD program is initiated.
Thank you very much for that, Elizabeth. We have time, I think, for one more question, and we have one from local public health here, specifically from London Goliard, who works for the Houston Health Department. And London asks Ben Blummel, can you talk a bit more concisely about the heart disease and stroke initiative that you mentioned? Is this something that operates in Texas or Houston specifically? Because London works for the Houston Health Department. We have a grant with the state of Texas for similar work in a specific part of Houston and would love to collaborate.
Well, we'd love to talk to you about it. The Project Impact Cardiovascular Health Plus that I was speaking about, that has the SDOH assessment, the stroke risk assessment, and then the EKG that's happening in the pharmacy with identification and referral to primary care physicians, cardiologists, and other specialists, along with ongoing monitoring and management services. We've just concluded a 2-year study on that, where we implemented in 2 of the Medicare administrative contractor regions. And so we have a model where that worked in 20 states with 40 different community pharmacies. And we'd love to have the conversation about seeing what we can do to bring that to other places.
All right, thank you. And I said one last question, but I'm going to take the chair's liberty here and combine 2 other questions into one, because they both relate to nutrition, and that's an important aspect of kidney health, kidney care management that we haven't discussed yet. So for folks with kidney disease and other health issues, what foods should be consumed that don't affect the kidneys, but also help with comorbidities? And related to that, um, let's see, where was the other one?
I answered it, so it went into the answered. Sorry, I shared a link.
Got it. Okay. Thank you very much, Jen.
So, Dr. Clymer, at kind of the national level, I can certainly start the conversation and just mention that the National Kidney Foundation has a nutrition hub, because one of the challenges in answering a question like that is that the answer is it depends. That particularly as kidney disease progresses, your food plan may change substantively. So the nutrition hub that's found at kidney.org looks at providing general information regarding nutrition for people living with kidney disease. There are perspectives on where different food groups fit in, what considerations are on the basis of the stage of kidney disease. We also offer recipes and tutorials that are associated with the preparation of the food, and all of this information is provided for free.
Very good. Thank you, Elizabeth.
If I can add on to that, your protein can be nephrotoxic, so it is important to restrict that to some degree as your degree of CKD goes up. And I generally write a diet that has 80 grams of protein in it, along with the decreased amount of sodium and potassium in that diet as well. But that guideline should be looked at. And also, to get that protein going in your body, you need something called leucine to make it go into the muscle and be incorporated. And that's included in yogurt, eggs, beans, and legumes.
Thank you very much, Dr. Maxey. So it pains me. I hate to leave any questions unanswered, and we have several more, but I need to move on right now to our an overview of our call to action. So I'm going to ask those panelists who are able to stay on, because if we have any time available, we will return to answer some more questions after the upcoming overview and discussion. But right now, I want to keep us moving ahead